Grazie, thank you very much, Alberto, and thank you for this lovely introduction. And it is my greatest pleasure to be here with you on a Monday evening. Surely there are some much nicer things that you might want to do on Monday evening, but tonight we'll devote this special evening to try to understand what we know about interdental cleaning, which are really the future direction. So without any further ado, please let me share my screen and I will move to the slide section. At the end, we will get back here and you are more than welcome to, of course, spending time with me and try to possibly address, I'll try to do my best to address any possible question you might want to have. So let me then move to my screen sharing, and I sincerely hope that you are seeing my slide. Otherwise, I would ask the courtesy to the organization committee to let me know in some way if the slides are not seen. So I would like to highlight more the issue of interdental cleaning. And first of all, let me just clarify that, as you might know, I'm from Pisa, which is by far the most beautiful town in Italy and surely in Tuscany, as I think everybody knows is in the world. And as you know, we are pretty famous for our Leaning Tower. But the topic of today will focus mainly on understanding periodontitis, then the issue of interdental plaque control, the effectiveness of the plaque control at the interdental level, and then some new insights based on the latest trial of my research group. And lastly, we'll try to draw some conclusion. So this is Roberto that you can see behind this slide. And Roberto, when I first saw him, it was 2005. I was 12 back then, and he was actually 34 years old of age in that specific moment. And you can see that Roberto is surely affected by periodontitis. And Roberto, all together with the other cases, do present a very important disease. Periodontitis is a crucial disease because, first of all, affects the vast majority of the adult population. If it is untreated, it would determine tooth loss. It is associated with numerous systemic diseases and conditions, and subjects with periodontitis do show an inferior quality of life. But the main problem with periodontitis is that if untreated, it would determine tooth loss. And as you can see, people with tooth loss present some significant alteration of their health. And it is most probably the severe periodontitis only, the sixth most prevalent condition in the world, affecting in the latest census 743 million. Now we know that we're nearly around 800 million of people affected by severe periodontitis throughout the entire planet. But if I go and check the whole case of periodontitis, not just the severe one or the advanced one, in fact, most probably 1 out of 2 is actually hit by periodontitis, and this is very true from the data from the United States. What is important, though, to understand, however, is not just the issue of the prevalence, but the issue of the incidence. When do periodontitis arrive? Well, I think it is very likely to understand the fact that between 35 and 40 years old of age is the moment where we have the highest amount of periodontitis affected cases, of new cases. And I think this is very much important because it's actually telling us that this disease is not a disease for, how could I say, it is not a disease of the eldest. It is not a disease of the third generation. It's actually a disease that is affecting mainly young adults that arrives at a young age, because as much as you might want not to deny it, but between 35 and 40 years old of age, a subject is extremely young. So it is a disease that affects the vast majority of the population. And I think this is very important. Everything starts with gingivitis, that we know we have a plaque accumulation would determine a local inflammation, which is very relevant, characterized by edema, swollen tissues, plaque, and so forth. So gingivitis is in fact triggered by the accumulation of dental plaque, and I am sure that we are all familiar with that. And being dental plaque, something extremely peculiar, a biofilm, so to speak, that is in a way sticking around our teeth in a very complex way, because it is really an ecosystem. It's a bioentity by itself that kind of sustain its growth by protecting itself with this matrix that encapsulate everything and creates this substance, which is really the base of the majority of the diseases that we have in the oral cavity. Now, the main problem is that we just don't need plaque to have disease. We need plaque, but we also need a susceptibility. We also need something that would determine the patient to develop more inflammation. So the higher the level of inflammation, the more prone is the subject to develop periodontitis. And this is mainly due to a more genetic influence, mainly subjects that do tend to develop higher level of inflammation, of inflammatory byproducts. It might be due to the subjects that might have some alteration of the metabolism of glucose, and this is classical example of diabetes. Subjects that do have diabetes or even pre-diabetes would actually be more likely to develop a local inflammation in the oral cavity. But then also stress and the overall balance between the challenges that we have in terms of societies and our well-being within our social environment, and in our own capability to cope with that. We know when there is an alteration of these would actually determine a stress-related disease, and periodontitis is very much related to that. But what is important also are our choices. Subjects that do smoke do actually tend to develop as well more periodontitis than others. So in the presence of plaque and the presence of something that would trigger higher level inflammation or an alteration of inflammation, the end result is the production of a loss of attachment. And loss of attachment is really the clinical sequela of the disease. So we assess loss of attachment, and that's what actually is the main sign of periodontitis. Now, the main problem with periodontitis is that, as we said, determined tooth loss, but also we need to face the fact that a subject that is affected by periodontitis is not just looking like Roberto. If we now look again at Roberto, he might really look like somebody with maybe unclean teeth, and surely you might give it to me that is really not the case of somebody you would like to kiss, to be honest. But instead of focusing on the teeth, if we would be able to focus at the gum level and to see what's going on all these pockets, and we would manage to put them one next to the other, we might most probably end up with an area of ulceration big as this one, big as this calf that is completely ulcerated. So that would actually make you understand how easy would be for bacteria to bypass from the external side to the internal side through the bacteremia. But it is not just about the issue of bacteria that may go in the bloodstream. It's also the fact that bacteria might trigger actually a systemic inflammation as well, because our body is so biologically clever that every time there is a local inflammation, there is always a backup from the liver standpoint in order to pump up an inflammation at the systemic level in order to defend ourselves. So this is really the base of the majority of the study that has been run for the last 20 good years in terms of the relationship between systemic and oral health. And in 2012, actually, we did meet between European Federation of Periodontology and American Academy of Perio to really highlight all this link between systemic and oral health. And nowadays, we can say that nearly 57 diseases have been associated to periodontitis. And it's actually very important for me to remember the meeting that we had with the International Diabetes Federation and the European Federation of Periodontology, supported by an unrestricted grant from Sunstar, in which we really highlighted that if you have periodontitis without having diabetes, you do tend to show a lower glycemic control and a higher incidence of diabetes, nearly the 30% more of somebody without periodontitis. But if you have periodontitis and diabetes altogether, you will show a higher rate of medical complication compared to somebody that just has diabetes. We know that the presence of diabetes in diabetic patients is associated with a lower level, for example, of kidney function or ocular problems. So understanding the link between periodontitis and diabetes is surely important. We have also run with the World Heart Federation another very important historical meeting in which cardiologists as well endorsed the fact that periodontitis cases show higher level of coronary and cerebrovascular diseases and even higher level of cardiovascular mortality. So really periodontitis can also be seen as a sort of a systemic disease per se, because the impact of periodontitis go even farther than the oral cavity. And I would invite you to sign the European Federation of Periodontology Manifesto, which is on our website. And it's very important because it's a call to action in this regard. But it's not just about systemic health. I had the chance to work a lot with Professor George Tsakos from the University College of London. And he's really an expert on quality of life, all together with these lovely participants from the School of Zagreb, Dr. Music and her mentor, Professor Bozic, in which we've highlighted the importance of the oral health and quality of life. People that are affected by periodontitis do show, in fact, lower level of quality of life. And this is very much related to the presence of symptoms. Surely you would understand, if you feel the breath of the jaguar, you're not going to ask your boyfriend out for dinner. So the importance really of the knowledge that we have in terms of quality of life is crucial to really understand what's going on when you have periodontitis. So to sum up this bit, periodontitis affects the vast majority of the adult population. Plaque plays a crucial role in its formation. So it is mandatory to prevent and manage periodontitis because of the important connection that we have between oral and systemic health. And you can follow our account on Instagram, which is the main source of the delivery material that we have nowadays. Or if you have any question, you might want to write there. So let me now move to the beauty of the Arno, which is the river that goes from Florence to Pisa and then to the sea. But surely the area around Pisa looks much nicer than the one in Florence. But and let me move with these wonderful pictures also to understanding the importance of interdental plaque control. So when I have these cases, I need to have in mind that my ultimate goal is to get to this point, a point where actually all the cases are under control and the patients are stabilized. So if that is the disease, bacterial inflammation would determine clinical sequelae, which is the attachment loss, I actually need to understand what, as a therapist, I'm going to do to the bacterial component of the disease. And surely there are 4 things that I do. I work with supragingival self-decontamination, I remove plaque accumulating factors, I debride subgingivally, and I might also use some adjunctive treatment. But therefore, supragingival self-decontamination is the base of my treatment. In fact, we know that it won't be sufficient to treat somebody with periodontitis, so teaching somebody that has periodontitis to brush thoroughly their teeth is surely not enough. However, you also need to understand that you can do any possible type of instrumentation, but if there is not a good plaque control from the patient, you will not see any results. So let me now work at the bacteria. What do we do here? When I have to teach somebody how to do plaque control, there are mainly two areas in which we work. We work on plaque control from a mechanical standpoint and also from a chemical standpoint. Mechanically, of course, you have the bucco-occlusal, which is mainly manual and powered brushing, the interdental, which is flossing, interdental, irrigator, wood stick, and then the chemical, the toothpaste and mouth rinse. But please, do forget irrigator and wood stick. I think nowadays we are pretty confident to say that these 6 tools are really the only tools that should be used in a way or another. Namely, you need to have one of each category to promote a good plaque control at home. Now, so what is the problem with the mechanical plaque control from the patient? Well, first of all, people brush very little. Let's face it. The majority of our patients would most probably brush around 30 to 45 seconds, at least surely the first time that we meet them. And we know that the highest amount of plaque is start to be removed after a minute and a half, actually 2 minutes. So less than 1 minute is actually not sufficient. It's really not the amount of plaque that we might want to achieve. And most importantly, if you, unfortunately, I cannot see you in the face now, and I wish I could be in Spain with all of you, but really all of us do remember when we start to brush, but none of us would remember when we finish, because it's a semi-automatic activity. Basically, it is triggered by the fact that I want to brush my teeth. But in reality, it's a sort of a mantra, it's a sort of a trance where actually brushing is kept by itself. And in fact, the mind of the patient wanders here and there, and I think what to do, what should I do during the day? And then magically, after a few minutes, I'll find the toothbrush in the glass in front of myself. So that is telling me that out of the 40, 50 seconds that somebody is brushing their teeth, mainly is only the first 10 seconds when one is really focusing on what's he doing. Now, the main problem is that when this person is brushing for the first 10 seconds, most of the time they're brushing the buccal surface of the central incisors, which are the surfaces that already per se are actually extremely clean. In fact, we know that, for example, that what would be important, it would be to address the amount of plaque that is actually located interdentally. But something that one needs to bring in mind, that to clean effectively interdentally is extremely difficult. It is not just difficult for the patient, it's actually extremely difficult for the dentist as well. And oral hygiene instructions are often taught too fast. They're not done properly with the structure. There are too many chemical agents. And finally, oral hygiene instructions are often made on models. So try to remember how long did it take us to understand that an X-ray or checking a picture in a slide is actually somebody looking in front of us. So to have this sort of a mirror vision, it took us a while. So it's really impossible that a patient for the first time would understand what to do just by mirroring itself with the model. So please throw the model away, well, dispose them ecologically, first of all, but focus on working directly on the patient's mouth. Every mouth is different from the other. We need to have a tailored approach. So how do I measure the performance of an oral hygiene tool? Well, first of all, I need efficacy and evidence. But also effectiveness that is based on compliance. So I assess efficacy by checking the data, but I also need to assess effectiveness by compliance. How many sessions do I need in order to make somebody capable to brush correctly? So first of all, I think it's important to assess the issue where the plaque goes. And I think that everybody is dirty in a different way. Dental plaque is mainly interproximal, and I think this is something that needs to be kept in mind. Plaque would tend to go in between teeth. Plaque is also accumulating mesiodistally, and there are 3 types of surfaces. The one with no plaque, which are mainly buccal, the one where there might be some plaque, and surely interproximal and molars are the ones where the plaque is actually located the most. So this already, it's already per se a call to action. It's already suggesting what we should do when we are aiming at teaching somebody how to brush. Well, first of all, interdental plaque is crucial because it's different from the rest of the plaque. And the reason is that we know that it's more acidogenous, so there is most probably a higher tendency to even develop caries. But I think what is important is the legacy given to us by the Axelson and Linde study from 1981, which is to me the base, the fundamentum of oral hygiene. Well, basically what they did, they took two populations, one control group, a large group, 180 subjects, seen once a year or more if they had symptoms or pain or so forth. Then they also had an extremely large test group when patients were seen 3 to 4 times per year and all the time were remotivated and were actually professionally taught how to brush. So it's a huge sample comparing to important issue, whether the presence or not of a continuous assistance in teaching and motivate subjects has an impact or not in terms of oral health, with a long follow-up, because we are talking about 6-year follow-up. So this trial is crucial, and let me assess what's going on in the control group. Buccal lingual plaque, without any possible motivation or instruction, in 6 years would actually show a diminishment of nearly half of it. That's very important because this data is telling us that the patient per se might brush a little better, in fact, between the buccal and the lingual surface. But what's going on interproximally? And as you can see, interproximally, the plaque is nearly the 100%, and down to 6 years, really, there are no changes whatsoever. So this data is very important. It's telling us that the patient by himself or herself, by themselves, can just brush better buccal and lingual, but they will not be able to brush better interproximally. So what is the impact of inflammation for somebody that actually shows this kind of plaque? So basically, consistent presence at the interproximal level of plaque and half of it in terms of the buccal lingual accumulation. So if I would follow the mantra that plaque and gingivitis and gingival inflammation goes together, I should think that most probably I would have a continuous inflammation interdentally, and there might be some improvement at the buccal lingual level because in fact plaque diminishes. But when we go and check the inflammation, we see that inflammation would tend to increase at 6 years, both interproximally, but also buccal lingual. This is extremely important because it's telling us that despite there is an improvement at the buccal lingual proportion in terms of plaque, inflammation would get worse. And why is that? Because the plaque at the interproximal level just stay there. So it's really the interproximal area that is modulating the level of inflammation. And in fact, if I go and check what's going on in the test group, the subjects that were seen 3-4 times per year and remotivated, you'll see that the plaque is really kind of nullified over 6 years. And that translates to a lower level of inflammation. So this is altogether another important data because it's telling us that by continuous motivation and support of the patient, even interdentally, plaque can be kept at a lower level. And if that happens, all the gingival inflammation is actually downer. And let alone the fact that even caries did not show up in the 6 years in the test group. So that brings us to a sort of a dogma that was given to us by Axelson and Linde, which I think is the base, with the first step of all my clinical practice, even when I do implants, when I do surgery, everything in the chain starts with one specific point. To allow orodental health in time, you need to make sure that there is no plaque in between teeth. So interdental area is the focus of oral hygiene. Whenever I have to do something, remember, first of all, the question is, have I taught my patient how to brush effectively in between teeth? That is the modulator of oral health. That is the key point. Teaching and bringing somebody and supporting a patient to be effective when brushing in between teeth. If that happens, then you can unfold all the rest of your perio. So now, before moving, gladly show you the beauty of Marina di Pisa, that, as you know, now nobody is going to Ibiza or in Mallorca anymore. Of course, they all want to come to Marina di Pisa, and by all means, I would rather you to come and me coming to Minorca, but that's a different story. And let me move now to the effectiveness of interdental plaque control. Now we saw how important that was. Now, the main problem is, of course, is the interdental area. And you can see that we have various types of interdental area. We in fact have a classical classification of the interdental area, which I think is something very important, because there are various types of interdental area, and therefore we need to think and apply our mind and understand how can I provide the best tool to each different type of interdental area. Classically, the data on interdental area are done in mixed patients between periodontitis and non-periodontitis affected. Keep this in mind for the latest part of my speech. So you see, interdentally, when we analyze what's going on at the level of interdental area, you need to bear in mind that biologically it's like a continuous tube of epithelium that has a very specific structure. You know, if you now look at these pictures, I'm sure that all of you, if you close your eyes, would in fact mainly see this area here when you open them. And that's kind of normal. Biologically, we are prone to check lighter image. So every time we in fact look in a cavity, in an oral cavity, in a mouth, our eyes would be captured by teeth. That's very important, because it's telling us that every time you want to check gums, you need to make an intellectual effort not to look at the teeth. So we look gums by avoiding looking at the teeth. Every time that we see a mouth, our eyes will go towards the teeth. So what's happening here, that when I see a papilla like this one, our mind reads it as a triangle. So we take the mirror, we check also the palatal portion of the papilla, and we see another triangle. And our mind reads it as a pyramid, because you see one triangle, another triangle, and everything is perceived as a pyramid. However, that is really not the case. Whenever I have a papillary structure, we have a complete different anatomy. A papilla is in fact a saddle that is made with two tips and a cord that connects the two tips. So it's really not a pyramid, it's something extremely long. And we need to keep this in mind when we're teaching somebody. Because you see, plaque, as we said, would go interdentally, and the majority of the plaque will be in between teeth. So we need to have a tool that is capable to clean effectively. The tools that we have are mainly three. We have flossing, we have interdental brushes, and we have picks. Let me see what do we have about floss. As you know, floss was considered to be one of the most important tools in terms of plaque control. When I studied dentistry, and that was, I finished in 1999, I was extremely young. I was 16, of course, as you know. And when I finished, I remember in the 90s, floss was really like a sort of a aristocratic level of the patient. When the patient was flossing, the patient was really like a top level. So ideally, we would have all liked to have our patient flossing. Would have been really the highest target. Now, flossing in somebody spoke a lot, but he's practiced very little. First of all, flossing is very complicated by itself because it's a dual movement. For each papilla, I have to clean two teeth, and I cannot do it simultaneously. I have to clean one tooth on one end and then the other tooth on the other hand. Normally, people think that this is something to be done by like shoe cleaning, but in reality, the movement are moving from the apical to the coronal portion. Now, that's very easy when we are flossing the upper central incisors, but you have to bear in mind how complicated it is to floss distal of an upper 6 or an upper 7. And so check, please, this case of plaque accumulation. This is a colleague of mine that was a few years ago. We did ask this lovely lady not to brush her teeth for a few days because I was invited to talk about the efficacy, actually, of flossing. And so I took some pictures, and this is me actually flossing, of course, with a tape. That was 2008 or 9, and back then I had finished my specialty 4 or 5 years before, so I was periodontist. I have good hands, and this is an area that is easily accessible. And this is the results after flossing. And you can see that really plaque control, I mean, I have not really diminished that much the amount of plaque, but it should have been something easy for me, surely, because that's the area where I can easily access. So that was very disappointing. And in fact, that was very much backed up by a wonderful, wonderful paper from the group from Friedrich van der Weyden and my friend Dagmar Slot, where actually already, well, my God, it's more than 10 years ago. But anyway, to understand the effectiveness of floss, the efficacy of floss, what they did was to call together all the papers that were comparing brushing versus brushing and flossing. If flossing would do anything, the group with brushing and flossing would have less plaque and less inflammation than the group with just toothbrushing. Isn't it the case? I mean, that sounds perfect. And so they took all this data with at least 4 weeks of follow-up. And what was important is that the majority of the data, we're talking about 8 out of 11, did not show any differences among the two groups, which is very important. You most probably might not give any treatment to any of your possible friends if the majority of the data would not show any relevance. And what is important, of course, anybody here might say, but come on, I know how to use floss. If you give it to a patient and you don't tell them that they should use this way or the other way, they might end up just playing with things with no specific action to do, and therefore might be very little effective. Now, however, you have to bear in mind that 3 out of this study that did not show any difference were actually made on dentists and dental hygienists. So not even us were capable to show that floss was giving a lower level of plaque. So usually when I say these things, I always have a guy that raises up his hand and says, come on, that is very true for the gums, but flossing is crucial to clean the contact point and therefore to keep plaque level and caries down. Now, I have to say, we don't really have much evidence, and studies on caries are different from the one on inflammation, but we do have some evidence of what's going on at the children's level, at the pediatric dentistry level. And it is clearly the case, that by flossing, there is a reduction of the 40% of caries in kids. However, that is true only when it's the dentist passing the floss 5 times per week, which means that only your child could benefit on the effect of flossing in terms of caries. So that data altogether brought also Berkshire to the conclusion that really there is really not evidence to support the usage of floss on a daily basis. And what's going on in terms of interdental brushing? Of course, when I started in 2005 back in Italy, the one in the left were the only toothbrush that we had interdentally. Now we have plenty of companies with different colors and adaptation that can actually easily clean any areas. One of the main difficulties in interdental brushes is that we tend to go for brushes that most of the times they're too small. So we need to make sure that we have toothbrushes that are big enough to clean all the interdental area that, as we said before, is longer than we might think. So what we do is really we teach the patient to go at the end of the interdental brushes, going back and forth for at least 10 times. But please bear in mind that each patient would benefit most probably with more than one interdental brush, because not all the embrasure, not all the interdental areas are bigger the same. And I think this is also extremely important and needs to be kept in mind. How many? Well, that's an interesting question. I have to tell you that more than 2 to me doesn't make any sense, because unless the patient is a psychopath, it's very unlikely that he will use more than 2. Actually, if I would have a patient that used 5 or 6 types and I will find him at the end of the day when it's dark, I'll be very scared. So I think 2 is enough. Then you might say, but what's going on if all the areas are cleaned? It's okay. It will survive. We will survive. The important is to shock the plaque control, to change. So having the vast majority of the interdental area clean, but I want to make sure that the patients will keep this in the long run as a habit. So I think 2 is a good number, but no more than 2. And always remember that this has to be taught professionally. In order to do so, what we do really is to, you see, basically I ask the patients to hold the mirror, then we use them so that the patient can actually see what's going on. And every time the patient sees, in his mind, her mind is telling themselves, it's something that it's possible, it's something that can be done. But then I think the most important thing is that when I hold the mirror and the patient is trying it, because that is the moment when the patient is empowered. That's the moment when the patient is saying, I can do it. And that is one of the most successful things. Every time that you teach something, the patient has to get out from the chair with something new, something that has been empowered to, so they can back home and try it again. You know, that's the only thing I do. Not me anymore, my team, but in the first session, the patient has to be able to clean in between teeth. That's it. We're not going to go anything else. In between teeth is crucial. We'll add the rest in a different session. So what we do really is to try to see all the cleaning, and you see I'm brushing properly in between teeth so that the patient can really feel that it's a brushing effectiveness, and there is a brushing technique. Then you see we ask the patient to do it, and as you can see, we dress them like this with oral hygiene instruction. But what is important is also always to highlight the fact that I will ask the patient to do it twice. So why am I asking the patient to do it twice? Here, I'm sorry, I had the audio, so I'm sure that that creates a bit of mess. But anyway, why do I ask again to brush? Well, that's very easy. Always remember that brushing is something you do in the bathroom, in the toilet. So it is not easy for anybody to show what you're doing normally in the toilet when you're wearing your pajama in the early morning. So it would be like having somebody sneaking at you while you're doing the shower, trying to correct the way you're cleaning your intimate parts. So what is really important, every time that you're bringing somebody to do a simulation of what they're doing in their toilet, they might tend to skip it. They might tend to say, okay, yeah, I understood it, okay, I got it. But therefore, that's why you ask it to do it twice, so that the patient gets less embarrassed and you really start to see whether you're making a change or not. And see, this is the plaque. This is the impact of interdental brushing. With interdental brush, you can see that there is really a difference and a change in terms of plaque control. Bear in mind that the interdental brushes may create trauma. And when they create trauma, like in this one, it's important. You can see there is an ulceration, patient feels pain, then you remove the brushes, you move most probably with mouth rinse for a few days until there is the re-epithelialization. Then you correct the inclination of the brush that happens when the patient is brushing towards up or towards straight, whereas they need to go a bit downhill because the teeth, as you know, are a bit tilted in the upper jaw. So that usually should be fine, or at least, or in the worst case scenario, you can change the, of course, the caliper of the interdental brushes. And let me show you the case of Veronica, a beautiful, beautiful lady, a beautiful patient of us that was being seen for a periodontitis stage 1. And you see that's the impact of interdental brushes. After 3 weeks, there is really a loss of the papillary area. Therefore, we move to flossing, and you can see the papilla that is growing back. So this is something that you always need to take on board. The brushes may create trauma. In that case, you need to swap to flossing. And every time you check and compare interdental brushing with flossing, there is no discussion. Literature from Dagmar's lot is very clear that interdental brushes works better. So this is the results that we presented already in 2015. You can see that I'm sponsored by Apple back then, and we highlighted the fact that interdental brushes are the device of choice for interdental cleaning. There is no discussion. Flossing should be recommended when interdental brushes create trauma. Other than that, interdental brushes are the one to be chosen. So, and this is something, these are the results of the latest consensus in 2019, when we actually established the guidelines of treatment, the recommendation of treatment at the for periodontitis stage 1, stage 2 and 3, and the main recommendation that toothbrushing should be supplemented by the use of interdental brushes, full stop. That's really the goal. Every time I need to teach somebody to clean effectively, I should supplement brushing with interdental brushing. So once again, you might want to follow us, our Instagram account. If you have a question, just pop them up there, because that's the only thing that I'm checking nowadays. But interdental cleaning is crucial. Interdental brushes show the highest performance. And when trauma after dental brushes is foreseen, then flossing should be considered, not vice versa. So let me show you the last pictures of our beautiful Pisa. This is the 16th of June, which is the day of Saranieri, when the all the lights are lit off and the entire town is lit by candles. And you see we are all there on the streets, kissing and getting drunk all together and dancing. That, of course, it will be, I don't know what will happen this summer, unfortunately. Surely last summer wasn't that pleasant as usually it is, but let's touch wood that next summer we're going to be all together. And of course, you're all invited to come. Let me show you the data of the latest insight that we've achieved with the 2 trials that we've run. First of all, what the trials were about was to try also to understand the impact of PICS, because that's a very interesting tool that arrived on the market a few years ago, but hasn't really tested them much. That's why we wanted to run the trial, to see whether that is effective or not, because they really fit in even extremely small areas. So they can be very good for the areas, for example, where trauma is foreseen instead of using flossing. So we ran a study, and that is published on the International Journal of Dental Hygiene, where actually we randomized group to 4 types of treatment: toothbrushing alone, or toothbrushing and flossing, toothbrushing and interdental brushing, or toothbrushing and PICS. Now, why is it so important? Well, this is important because we also divided the follow-up in two moments. The first one was the usage of the device with the patient unclean, and it's called unclean phase, which is important because it really gives you an idea of the rough efficacy of the tool per se in removing plaque. But I also did design then, of course, a clean phase, so patients were clean, and up to 4 weeks was followed by. So patients were very young. We're talking about subjects in the 20s. Why this is important? Because these 2 trials, I wanted them to be one on periodontitis healthy affected patients, and the other one was on periodontally healthy ones. So this one is the results on periodontally healthy one. So subjects that have entire papilla present. And this is important to stratify when you check the literature. In the old papers, all patients were put all together, but the papilla anatomy has a tremendous impact in interdental cleaning. That's why I did design the study on 2 different populations. So in periodontally healthy subjects, I think what is really important is to see that all the 4 groups had, of course, an impact on plaque. But when I go and check interdental plaque, which is the plaque that you can see interdentally, basically the subjects that were treated with interdental brush and rubber interdental PIC showed more plaque reduction compared to toothbrushing alone. But what is important is that when I was checking the gingival inflammation, the highest reduction was actually seen with the interdental rubber PIC, and that was significantly different from the one that were using floss. So this is important because the amount of plaque was reduced the same by interdental brushes and interdental rubber PIC, but the inflammation was more reduced interdental rubber peak compared, for example, for flossing. And the only reason that can come to my mind is that most probably the nature of the rubber, the structure, may also create a sort of a massage, most probably, of the pupillary area, and therefore maybe a drainage, therefore maybe a more effectiveness in terms of dealing with gingival inflammation. So this data is published. You can find the International Journal of Dental Hygiene. And now, with the greatest pleasure, I'll present for you for the first time in the world, and now you can see the noise and champagne that is popping here and there, but these are the data, and this is the first time that I'm showing them. We just analyzed, we just finished the paper that will be sent, which is the results of what's going on when you do the same trial in subjects with severe periodontitis. You see, now it's a different population. It's a population in their 50s, well, nearly 50s, it's 49, 50, so forth. Subject with a higher level of plaque, higher level of inflammation, but the groups are the same. Now, what is important that all groups achieved healing, and no worries, I'm not going to read you all the tables. I think what is important that the two groups with the interdental brushes and rubber peaks are the one that reduces more angulated bleeding score and interdental angulated bleeding score than the other groups. So these two groups were more efficacious than others. So to conclude these two groups, the use of interdental brushes in healthy subjects and rubber peaks reduces more interdental plaque, and inflammation is decreased more with peaks than floss. And in subjects with periodontitis, the use of interdental brushes and rubber interdental peaks is actually equally efficient. So peaks are effective as much as interdental brush in dealing with subjects with periodontitis. However, bear in mind that when you're using rubber peaks in subjects with periodontitis, you need to make sure that you adjust and you use the right caliper, the right dimension. Otherwise, you might be underpowered. So to sum up with the view from my bathroom, once again, if you have any question, just write to me on Instagram. But the interdental cleaning is the cornerstone of gum and oral health. There is no discussion about this. Interdental brushing appear to be the most effective techniques in terms of performance and compliance. And rubber peaks do also show a high level of performance in both health and periodontitis affected subjects. And I really think this is one of the tools that we have nowadays in the future. So let me, of course, for the one of you interested, I will suggest you to go to our website, PerioCampus, because in PerioCampus you can see and you can download PerioCampus Herald, which is the journal that we designed for the periodontist, a journal that is based on understanding issues that are important for us. But at the same time, it's not a scientific journal. It's a narrative journal written by periodontists for all colleagues that are interested to check. So with this in mind, I would just lastly pay a tribute to one of the greatest mentors that I could possibly have, which was Professor Bob Janko, which unfortunately and sadly passed away early this year. So, dear friends, I've now done with my lecture, and do let me see if some questions arose. Let me see.
Sono qui.
Oh, salve.
I'm
Salve,
here.
Alberto. Very good to see you.
Thank you again. We really appreciate your knowledge, and we are really thankful having you sharing them so generously. We have some questions from the audience now, and we can start if you agree.
Absolutely.
So, with improvement of tools available for patients, did you see an improvement of interdental cleanings in the latest years? Do you think that people are in general more using interdental aids now?
Yes, absolutely. There is no discussion. People is using this much more frequently, and the reason is very clear. Well, first of all, you have to bear in mind that they are more available. So, in fact, what is happening when they go to the supermarket, to the shop, people might find interdental tools more frequently, and therefore might use them, let's say, more easy. They might find them much easier. So, and at the same time, I think there is also an higher impact for what is going on in the television. You know, people see that most of the time subject in TV to use flossing and so forth. So there is a higher tendency for sure. So yeah, no discussion.
Good. Another question is, how do you ensure compliance with interdental cleaning with your patients?
Well, basically, as I said, the first time we teach interdental cleaning, then the second time we check if that is okay. And only when it's okay, we move towards the power toothbrush. We don't go to the toothbrush unless the interdental cleaning is okay. And we check it with plaque control. I mean, with plaque disclosing solution all the time.
Another question from Martin. Dear Professor Graziani, thank you for this very nice presentation. After seeing this, I really want to visit Pisa very soon. A question about your presentation. Compliance is very important, as you mentioned. Do you see differences in compliance between, for example, floss and interdental brushes or soft picks? I think this is a similar question.
Yes, I think, well, first of all, I'm impressed that Martin didn't see Pisa yet, first of all. Which is very disappointing. But I think what is important, and I would thank for the question because it allows me to expand more in this issue. We focus efficacy, so how much interdental brush removes plaque more than flossing. But surely effectiveness, which is the compliance, is even higher. It actually takes usually just one session, maximum 2, to bring somebody to be effective in cleaning in between with the interdental brushes or picks because the movement is the same. But flossing, there are patients that you might spend 6, 7 sessions and they're still not capable. I'm personally not capable to floss behind my 6th. They're too complex. My finger are too big. I don't get there. So yeah, surely there is an impact in compliance. No discussion. Thank you.
Another one, have there been injuries regarding the rubber interdental brush?
No, not to my, I mean, we haven't reported in both trials any injuries, no. I mean, at least the one that I use it with me or to my patients didn't report any trauma.
And how many times per week do you recommend your patients to clean interdentally? Minimum, in experience, they tend to do 2 or 3 times maximum.
Well, I think we are ready to go for a paradigm shift here. The paradigm shift is telling us that it should be the opposite. How many times the patient should brush normally, but the base should be interdental cleaning all the time because we saw that interdental cleaning is the most important. So my patients do go interdentally morning and evening every day, no discussion. And I always tell them, if you have time left, then you use your toothbrush. And of course, psychologically, they will always use the toothbrush. They cannot get rid of it. But what is important is to highlight the importance of the interdental brushes. 2 or 3 times per week is not enough. They need to do it at least once a day.
Good to know. Thank you. Thank you for this nice presentation. What do you think about the efficacy of mouth rinses in the interdental area? And do you recommend it systematically?
Well, I don't recommend mouth rinse systematically. I do recommend mouth rinses only for some specific occasions, you know, some moments of lower plaque control, some moments of high level of inflammation, but normally no, I rely more on chemical plaque control than, on mechanical plaque control than chemicals. So chemicals, I use them when I want to supplement something or I really have somebody that is not capable to brush. But I have to say to my experience, and I have done this job of 20 years just checking at gums, other people's gums, and usually the vast majority of the people is perfectly capable to do it. So mouth rinses for me is just for some specific moments.
Okay, we are having a lot of questions, but we are running out of time. So we are going with the last one.
Okay.
Says, another professor question that can break the thin epithelial layer damaging gums. What do you think about this point of view?
Well, the other professor is not as good as me. That's very easy. No, what I want to say is that I have no problem. I mean, interdental brushes, they're not going to ruin any epithelium. Epithelium is more than strong by itself to regenerate itself every few days. We have plenty of layers of epithelium. You're not going to destroy anything just by brushing it. Just think about the action of food on the gums. If that would be the problem, would destroy all of us and would depithelize of the gums. So do not worry, just brush and you'll be fine.
Okay, so Dr. Graziani, on behalf of SEPA On Air and myself, I have to insist, thank you again for your presentation and your kindness. If you want to say something to the audience.
Well, I can just say that I love to be here, but I'm really looking forward to the moment that I will be finally be in person once again in congresses. I'm so bored of webinar. I've been giving hours and hours sitting in front of a screen of webinar since February, and I cannot get rid of it anymore. Please, let's heal from this COVID. Let's go out from this pandemic and let's start to travel again, have a beer and talk as human beings should do. Lots of love, just have fun and enjoy your evening, your Monday evening, okay?
Thank you very much. And good evening to all the audience. Thank you all. Good night.